moving forward is which of these biomarkers should we really pick to implement in clinical care.
There was this noise coming from the corner of the mouse facility, and we realized that our mice are very active during the day. So we wondered if they have a circadian disruption.
For nephrologists who treat patients over a really long period of time, the relationship is actually quite essential.
Welcome to the ASN Kidney Translation Podcast. I'm your host, Dr. Matthew Sparks, a nephrologist at Duke University, also serving as the communications editor for the ASN portfolio of journals, JASN, Kidney 360, and CJASN. Our mission is to deliver insights from the latest advances in kidney medicine and engage in a meaningful discussion on how these breakthroughs will directly impact patient care. In this episode, we delve into autosomal dominant polycystic kidney disease, or ADPKD. Joining us are Dr. Rao from Kansas University Medical Center to unpack her recent paper published in JASN, shedding light on the relationship between circadian rhythm and cyst progression using mouse models. Additionally, we will hear from Dr. Seliger and first author Carolyn Yee, a medical student from the University of Maryland, who will discuss the association between depression and ADPKD featured in Kidney 360. And that's not all. Dr. Baes from the Netherlands will also guide us through an original investigation in CJASN, examining the results of a biomarker analysis study in a cohort of patients in ADPKD. Join us on a journey into the forefront of kidney medicine, where groundbreaking research meets real-world patient impact. We will start with Dr. Rao from the University of Kansas Medical Center. Welcome to ASN Kidney Translation Podcast.
My name is Reena Rao. I am a professor of medicine and the deputy director of the Jared Grantham Kidney Institute at the University of Kansas Medical Center.
Well, welcome. This is a really provocative paper and really caught my eye. So I never really thought that there would be any connection between circadian rhythm and polycystic kidney disease. So I guess the first question is, how did this project come about? How did you link these two topics together?
During the COVID pandemic, we spent a lot of time in the mouse facility, and we had a bunch of mice, polycystic kidney disease mouse models, which we had left in a corner of our mouse facility to age out. And what we found was that these mice were very active during the daytime when they should have been really sleeping or resting. So there was this noise coming from the corner of the mouse facility, and we realized that our mice are very active during the day. So we wondered if they have a circadian disruption, and we found a colleague who works on circadian biology, and we started from there. And we had some reason to look into PKD. Although we don't have any clear scientific evidence that PKD patients have circadian disruption, I want to point out that PKD patients have non-dipping hypertension, or their blood pressure does not drop in the night. And blood pressure is a very circadian physiology. It is higher during the day and it dips in the night. So they have non-dipping hypertension, and they have polyuria, nocturia, and polydipsia, which means that they might have sleep disruption in the night. So there are some clues that they might have circadian disruption. So that's where we started.
That's very interesting. The colleague that you're referring to is likely Dr. Gums, is that correct?
Yeah, that is correct.
Well, she's definitely one of the leaders in this field.
Yes.
Okay, so you noticed the mice were moving around during the day, and just for our listeners, mice sleep during the day when it's light out, and then when it's dark, they get up and they forage and they find food. So they have a different circadian rhythm than humans do. So I guess that was one of the things with the pandemic, that you started doing things that you usually don't do, like, for instance, spend most of your time in the mouse colony.
We had to work in shifts, so some of us had to come in the night.
You gave a couple of clinical clues as to maybe their circadian disruption. One is they have non-dipping blood pressure phenotype and hypertension. Two, they have this polyuria that typically occurs at night. So there's a lot of genes associated with circadian clock. Can you tell us about what you did to sort of explore if they had any changes in these circadian genes before you sort of jumped into the mouse models?
I have to give a little bit of background on circadian rhythms before I explain what the genes are. So circadian rhythms are like intrinsic cyclical 24-hour oscillations, basically in our behavior and our physiology that helps to coordinate our biological process with the time of the day. And the external cues are generally sunlight and food. So the circadian rhythms are at the fundamental level, at the molecular level, regulated by the molecular clocks or the circadian clocks, which are a bunch of proteins. And these are called clock proteins. And there are 4 core clock proteins, and it's one clock protein that we have studied extensively. Its name is BMAL1. But to start off, in the human, we looked at human nephrectomy kidneys. So these are probably ESRD kidneys, which were nephrectomized. So when we looked at these kidneys, they looked at the mRNA levels of clock genes, we found that they are significantly different than the normal human kidneys. So the ADPKD kidneys had different pattern of circadian clock protein expression or gene expression compared to normal human kidneys. So this is where we got a clue that human ADPKD patients probably have a clock disruption, at least in the ESRD kidneys.
Can you describe a little bit more about what was different about it? Did they have higher levels? Was it just each gene was a little bit different? What did it look like?
The 4 clock proteins that we have are BMAL1 period genes, and then clock gene and the cry genes. So we found a significant decrease in the BMAL1 levels. And as I mentioned earlier, BMAL1 is the protein that we extensively explored in our study, in the mouse study. And we found increased levels of the period genes and a significant difference in the other 2 genes, the cry and the clock genes. And there are also multiple other auxiliary genes, clock genes, and we found difference in some of them. But what was very interesting is that in the ESRD kidney, we can have differences because the kidney has stopped functioning. So we went down to the cell level, at the level of like the collecting duct cells and proximal tubules. We have cell lines for proximal tubules and collecting ducts, which are knocked out for PKD1 gene. So we looked at these and we found that the wild type collecting duct and proximal tubular cells, they have very clear oscillations. They oscillate every 24 hours. They come up and then they go down in their gene expression. But in the PKD1 knocked out cell, those cells had depressed, or the clock genes did not oscillate. So they had lower expression and lower oscillation. So that's how we found out that these cells, now the cells which are growing in culture, they do not see the sunlight. So this is a free running clock that we are looking at. So PKD1 gene mutation or knockdown by itself can disrupt the clock. So this is what prompted the rest of the study in mice.
So I guess now that you've done these 2 experiments, one in human tissue, which rightfully it would be hard to get human tissue every few hours. So, and then moving it to the cell culture, and you note that there are problems in these cells that do not have a functional polycystin 1 have derangements in these genes. So that's really interesting. So why don't you tell us about how do you take this question to the mouse and be able to really look at whether or not these clock genes play a role in cyst development?
The thing is that when we found that there is possibly circadian disruption happening in human patients and in the very older mice which have very highly cystic kidneys, we have this problem of what comes first. Does the circadian disruption cause disease progression, or does disease progression cause circadian disruption? So we decided to ask this question at a very early time point when the mouse kidneys are just starting to develop cysts. So we analyzed the clock gene expression in mouse models at different ages, and we found that in the very early time points, the clock is not disrupted in the PKD mice. So the mice that we looked at in this study is actually a hypomorph for PKD1 gene. So this is not like the mice in which PKD1 is completely knocked out. We did study those mice also and found that at any point of time in the mouse where the PKD1 gene is completely knocked out, the clock is disrupted. So this mouse, called the RC mouse, it is a hypomorph for PKD1 gene. So these mice at a very early age, they do not have much cysts and the clock is normal. So we decided to disrupt the clock at this point by mutating a clock gene. And we used this to compare it with a human, with a patient who might discover that or who might have ADPKD, but the disease is not progressing rapidly at this point. If this person exposes himself or herself to a condition where there is chrono disruption because of shift work or untimely food consumption, disrupted sleep patterns, etc., then will the disease progression, will the circadian clock be disrupted? And these shift work and things that I mentioned are all known to cause circadian disruption. So does the circadian disruption lead to accelerated disease progression? So this is what we were trying to do in the mouse. But because disrupted sleep or untimely food can affect the whole body, it's a systemic effect. We wanted to very particularly go down to the molecular level and disrupt the clock by knocking out a clock protein. We felt that to start with, this would be the best method. So that's why we knocked out BMAL1 gene, which is a core clock protein, in the collecting ducts of the PKD1 mouse. So what we found was that the disease progression became very rapid. The cysts were much bigger. There were more cysts in the kidney.
First, I just want to point out to the listeners that if you pull up figure 2 and look at panel B, this is where they had the kidney sort of sliced, where you can look at the cyst, and it is very dramatic. I always look at basic science and say, if you don't need statistics, you really got something. And you do have statistics here that shows very low p-values, but you can visually just see how striking the number of cysts are in the mice that have this PKD mutation and also the clock disruption as compared to those with just the PKD itself. So that's really interesting. And I'm trying to listen back to what you were saying. And what I heard was that you sort of picked a model that was hypomorphic, meaning that they have a disrupted PKD1 gene, but it still functions a little, which might be a little bit more like we typically see in humans, whereas the full-fledged PKD1 knockout is a pretty aggressive phenotype, and it might not recapitulate the human sort of feel as well. That's really impressive, and thank you for going through all of that. Before we go on to the details, I was curious, do you think, and is it possible to alter the day and night, or basically alter the circadian rhythm of the animals so they have changes in these genes without disrupting them with knockouts? Do you think they would have the same phenotype? Is this something that you're planning on doing? Is it feasible?
So we were funded by the DoD to do this project that was published. So we have preliminary data to show that mistimed feeding, that is feeding at the normal resting time of the mice, which is during the daytime. So we don't feed them in the night, but we feed them only for a particular number of hours, that is 8 hours during the daytime. And that we call it mistimed feeding. Or if we do sleep fragmentation, so we don't let them sleep continuously. So these two methods of chrono disruption, we find that it aggravates the cyst growth, it accelerates cyst growth, and the kidneys are highly fibrotic and cystic. So we have some preliminary data on this already.
Well, I have to also say, as someone who is a recovering basic scientist, this is a really expensive set of experiments. If I'm looking at this correctly, you have 5 different mutations on these animals. PKD, 2 mutations, 1 on each allele. The floxed gene for BMAL, and then a CRE.
The good thing about our science is that science is very collaborative. These mice were all not made by me. For example, the PKD1 floxed mouse, PKHD1 CRE, these were from Dr. Somlo, and the RCRC mouse model we use is from Mayo Clinic, Dr. Harris, and the Cat Hop. And so we bred together these mice and performed experiments. We developed some in vitro models, though, where we had to make CRISPR-Cas mutagenesis to knock out BMAL1 in cells to look at mechanisms.
How long do you have to let the mice live in order to see those cysts in figure 2?
So these mice, based on the background, their cyst growth can be different. So the mice which we have shown in this paper, they are on the C57 black 6 mice. So they are slow progressing mice, and the mice are, the picture is from 8-month-old mice. So the mice had to be kept for 8 months to see that phenotype.
8 months. Wow. I know the hypertension studies that we do are like 8 weeks. So that's 8 months is quite a lot. Also, that's very interesting that I know that in diabetes and other diseases like hypertension, C57 black 6 have a similar phenotype where they're a little bit more resistant. So that's very interesting as well. Now that you have demonstrated that disruption of clock genes is disruptive to cyst growth, can you sort of then walk us through, like, why is that?
So we looked at mechanisms. So seeing such a big phenotype, when we knock out BMAL1 in the collecting duct, we see that the cyst growth is much more rapid. There are larger cysts, and the kidneys were also very highly fibrotic. So we went and looked for mechanisms. So there are papers out there which has done chip assay. So you see, BMAL1 is a transcriptional factor, so it binds to DNA. So we wanted to see what genes are they regulating. So they can regulate other genes, and there are chip-seq analysis that has been done which gives us lists of them. So we went and looked at those to see if any of those genes are changed. Yes, some of them were changed significantly, but we could not make any direct link to disease progression. So then we went down to metabolism, and we looked at the glucose metabolism and fat metabolism. In glucose metabolism, we could not get any strong clues. But when we looked at fat metabolism, we found that basically, let me give a little bit of background about ADPKD and fat metabolism. In ADPKD, it is already known that fatty acid oxidation is reduced and fatty acid synthesis genes are increased. So there is possibility that there is, at least the data suggests that there is accumulation of fat in the kidney, and this is pathogenic. So we looked at fat metabolism related genes, and we found that fatty acid oxidation related genes are suppressed and lipogenesis or fatty acid synthesis related genes are increased. And we looked at triglyceride levels, which is basically fat storage in the kidney. And we found that triglyceride levels in the kidneys of these BMAL1 knockout mice is increased. So we went down to the cell culture levels. So PKD1 knockout cells divide more in culture. They divide more, or they divide more rapidly than the wild type cells. So we inhibited triglyceride synthesis, or we inhibited the fatty acid synthesis related genes in the PKD1 knockout cells, and we found that the cell proliferation can be inhibited. So basically indirectly showing that this accumulation of lipids, which is stimulated by BMAL1 knockout on the PKD background, because we didn't see this in the wild type. In the wild type, we could not see accumulation of triglycerides, but BMAL1 knockout in the PKD1 knockout mouse as well as in the knockout cells, we find that there is accumulation of lipids. And this could be one mechanism for the accelerated cell division in the BMAL1 knockout RCRC mouse.
You recognize that potentially there could be an alteration of proliferation of cells, and this could be linked to fatty acid oxidation that has been seen in other PKD models, and it seemed to be playing a role here as well.
That's correct.
Very interesting. I'm curious, what clinically, if this holds up in human studies, what can be done to restore circadian clocks in animal models and maybe even human models?
That's actually a very good question, because I find the study to be important at two levels. It is basically showing that chrono disruption could be a risk factor for rapid disease progression, but it also shows some possibility for chronotherapy. So when we talk about chronotherapy, generally use three important terms. One is clocking the drugs, the second is training the clock, and third is drugging the clock. So clocking the drugs, we are all very familiar with. Basically, we are optimizing or standardizing the time for drug treatment for two reasons. One is to improve its efficacy, and second, to reduce side effects. So deciding which is the best time. For example, We all know about statins, which is one of the most commonly used drugs. Its target, HMG-CoA reductase, it has very clear circadian patterns in the liver. So finding the correct time when, for example, another example is V2R inhibitors. If we give tolvaptan to a patient when V2R is not being expressed in the kidney, then there is really no use. So that's the thing about clocking the drug. We might be able to use the drugs at the correct time. Second thing is training the clock. So clock can be trained using behavioral methods like time restricted feeding or using light and dark phase cycles correctly to change the clock settings in a cell or in an organ. So it's basically light and food that is used to train the clock. And the third and most important thing is the drugging the clock, which is still not very well worked out yet, because we are thinking about pharmacological modulations. Here again, we have that problem of chicken and egg kind of a problem. If drugging the clock is going to change the clock, will it again result in disease? So what the field of cancer of circadian biology has come up with is, instead of targeting the main clock proteins, the core clock proteins, there are auxiliary clock proteins like rever B alpha and beta. So we can drug those, and the auxiliary clock proteins actually help to not mess with the main clock so much and cause a lot of difference. But these are important transcription factors which can help to probably fix the clock and the downstream effectors. So we are testing some of these. Some of these are already tested in some various diseases, and we are trying to test that in PKD.
It's very interesting. Well, any last comments that you'd like to make about this paper, and what are the next steps that you and your group are looking at?
Families which have the same kind of PKD1 gene mutation, the members of that family can have different progression of the disease, which means that factors other than the PKD1 or PKD2 gene mutations can regulate disease progression. And we already know about some other factors like acute kidney injury or stone formation, which can alter the progression of a patient's disease progression. But here we are showing for the first time that circadian clock also can regulate it. That is, circadian disruption can alter the progression of the disease. So our current focus is on looking at environmental factors that can alter it, like I mentioned earlier, mistimed feeding and sleep fragmentation. And what are the mechanisms by which these environmental factors can alter the disease progression? And second is to try chronotherapy by behavioral modifications or by pharmacological approaches. We have some targets that we have identified, and we want to pursue this.
That's wonderful. One of the first questions you ask a patient who has polycystic kidney disease is, what age did your father, mother, whoever it may be, start on dialysis? And you look at that and you want to be able to tell that patient that here are some things that you can do so that you don't start dialysis at that young of an age. And we can push that as far as possible. We have drugs to do that, but I think this is really an amazing study that brings some new hope. And I hope that this can be translated to humans. So congratulations to you and your group for this really impressive study, and we really appreciate your time. Thank you so much. For the listeners, tune in to the next topic where we'll be having a complete review of different studies in the ASN families of journals covering polycystic kidney disease. Thank you, Dr. Rao.
Thank you.
Welcome to the ASN Kidney Translation Podcast. I'm your host, Dr. Matthew Sparks from Duke University, and I'm here with two guests to talk about their recent publication in Kidney 360 titled Depressive Symptoms in Adults with Autosomal Dominant Polycystic Kidney Disease. So welcome to ASN Kidney Podcast to both of you. The next paper we'll be covering in ASN Kidney Translation Podcast is published in Kidney 360. It's titled Depressive Symptoms in Adults with ADPKD. We'll be joined by Dr. Seliger and a medical student and first author, Carolyn Yee, both from the University of Maryland. Welcome to the ASN Kidney Translation Podcast.
This is Steve Seliger, and I'm an adult nephrologist and epidemiologist and a faculty at the University of Maryland School of Medicine, where I am the leader of the Clinical and Translation Core of the Maryland PKD Research Translation Core Center. Good to be here.
My name is Caroline Yee. I am a third year at the University of Maryland School of Medicine, about to be a fourth year in about 7 days. And I worked with Dr. Sellinger on a research project during my MS2, MS3 summer.
So tell us, how did you find out about this program?
During my MS1 year, Dr. Terry Watnick came to our school and gave a little talk about her research. We had a round robin discussion, kind of switcheroo of different PIs who came and talked about the research. And I was really struck by, I think, first, her dedication to student training and education. And second, it sounded like she had a really good data set. So I was very excited about that.
So it's a kind of a speed dating session, and you heard about this. So that's great. I think the more in depth you can explore a different subject, the more likely you are to enter into that field. So really happy that you had this experience. So let's take a step back and just sort of talk about this manuscript as a whole. Obviously, depression, anxiety, all these are really important. What makes it unique in autosomal dominant polycystic kidney disease?
I think part of the relevance to autosomal dominant polycystic kidney disease, or ADPKD, is that, of course, first and foremost, this is an inherited disorder. And so that the patients who present to us for care, and many of those who participated in our research observational study, were one of several generations and several members of their family with this disorder. So many of them who were diagnosed, for example, early in adulthood or sometimes even late in adolescence, were being diagnosed with a disorder that perhaps they had only mild symptoms at the time, but knew from their family members was likely to progress on to kidney failure, or at the very least to advanced kidney disease, along with the other complications and manifestations of this disorder. So we were interested in understanding how this might translate to the experience of patients affected with this disease in terms of symptoms of depression and anxiety. And this is an area that has been addressed, actually, since we started this project, has subsequently been addressed in the recent KDIGO clinical practice guidelines for ADPKD, which highlight the importance of assessing depression and other symptoms of psychological distress in ADPKD patients.
Well, what was known about this topic in depression and ADPKD prior to this publication, and what were the research gaps that you were trying to close?
I think in summary, the existing research was a little bit complicated to understand because some studies found that patients' depression worsened as their disease progressed. And then other studies found no relationship at all. So that was hard for me to understand. And then there were different patient populations. So patients with end-stage kidney disease, some of them got worse as their disease got worse, and some of them stayed the same.
So I think that there was some conflicting research, conflicting results from different studies on this. And there was some suggestion that the severity and that its progression of PKD was linked to worsening depressive symptoms, but others that didn't find clear associations with the severity. And the severity in ADPKD we measure usually by both the estimated GFR, but also by the kidney enlargement with a radiologic measure of total kidney volume. And there were some large studies previously that didn't find that total kidney volume was really associated with symptoms of psychological distress, depression, and anxiety. And so we were interested in trying to address this question in a large regional cohort, and one that had validated measures of depressive symptoms measured longitudinally.
Very interesting. So some conflicting data. Definitely, it does sound like there needs to be something that was a little bit more prospective in nature. Can you tell us about the methods that you used in trying to answer this question about what is the burden of depression in PKD?
We were able to take advantage of an existing longitudinal cohort study that we had founded nearly 14 years ago here at the Maryland PKD Research Center. And we have enrolled over 250 adults with ADPKD from the Mid-Atlantic region, not just our own patients at University of Maryland, but patients from other areas, Washington, D.C., Virginia, Philadelphia, Delaware. And this study was designed to really create a rich database and resource for further investigations into multiple aspects of ADPKD. So when Carolyn joined our research center as part of our summer research project, we had already collected data on over 250 patients. And as part of the phenotyping of these patients, we had asked them about symptoms of depression, multiple symptoms, using a well-established instrument for ascertaining depression, in this case, the Beck Depression Inventory.
Wow. So you already had the foresight to sort of ask this question many years ago, and you'd been collecting this data. So it was like really primed for you to look at, as also it appears simultaneously it starts to get put into guidelines.
Right. In fact, when we started the project, the guidelines were still in development, and neither of us were aware specifically of how they might address this. But this was a question that I had suggested that Carolyn might be interested with, particularly with her evolving interest at the time in mental health and behavioral health, and something that might be a relatively unique resource to use to answer that question, because we had so many measures of depression longitudinally tied to measures of PKD severity and progression.
So it can actually get at some of the granular questions, like maybe if PKD has a worse phenotype in your family, just is depression worse, for instance? Is there a certain set length of time they had to be prospectively followed before they got included into the depression study?
We had some patients that we just had the baseline data on, and then some patients that we tracked over the course of 36 months, but not all of the patients in our cohort we were able to follow for the 36-month period.
And it is an ongoing cohort with ongoing longitudinal follow-up. So, of course, some of the participants had been enrolled only recently. They hadn't reached their 36-month follow-up period. Others that had been enrolled in the past, a few of them, unfortunately, had gone on to end-stage kidney disease already, so were no longer being actively followed at the time. But the 36-month was the planned follow-up, and we had designed that originally when we started the cohort study with the thinking that that would be a long enough period for this gradually progressive disease to see changes in kidney function, kidney volume, and potentially changes in associated symptoms and other patient-reported quality of life changes.
Let's move on and talk a little bit about the methodology here and the baseline characteristics. So how many patients? Can you tell us about those sort of things?
So we had used, as I mentioned, the instrument called the Beck Depression Inventory. The second version of this is a long-established, well-validated, and widely utilized multi-question instrument, which really tackles multiple domains of depressive symptomatology, both the symptoms that we would consider affective. So, for example, feelings of down and hopelessness, but also the somatic symptoms that can be associated with depression. For example, loss of appetite, feeling tired. Now, of course, we also appreciated that some of those latter somatic symptoms might themselves be also manifestations of advanced polycystic kidney disease, particularly in those with massive nephromegaly. So we did understand that there were different aspects of depressive symptoms that were being quantified. But this instrument has been used although we were not aware of it's being used in large studies with PKD, it has been used in other studies of other patients with chronic kidney disease. That was the primary, for example, exposure variable in this case, or ascertainment of depression. We ended up with 283 patients who had initial evaluation for both their depressive symptomatology and PKD severity, and that formed the baseline subpopulation or cohort for this analysis.
And so we defined an abnormal BDI. Importantly, this is the BDI-2, not the BDI-1, as some prior studies have used. So an abnormal BDI-2 score of 11 or greater, we classified as having quote unquote moderate depressive symptoms. And then anything less than 11 was no depressive symptoms, or I guess not clinically significant depressive symptoms.
The Beck Depression Inventory is a 21-item questionnaire, and each item can be responded on a scale of 0, that is absent, and 3 to severe. So the range of scores is 0 to 63. We choose a cut point of 11 as one that had been previously recommended as indicating the possible presence of a depressive disorder. We should note, though, and we note this in the manuscript, that the Beck Depression Inventory is not intended as a substitute or as a diagnostic tool for depression. It is a screening tool for depression and a tool that quantifies symptoms. So we are careful to indicate that we are not able to assess purely on the basis of the responses to these questions whether a patient suffers from major depressive disorder as diagnosed by standard psychiatric criteria.
And I guess also you have information on clinical diagnosis as well of depression.
We have some incomplete data. I would say I don't think the number of people who have reported depression as one of their past diagnoses, I feel like that is underreported.
We asked patients about all of their chronic medical conditions and then all the medications that they were using prescribed and over the counter. And on the basis of the responses to these questions and other information in electronic health record, we attempted to determine how many had been diagnosed clinically with a depressive disorder and how many were taking medications that are commonly used for antidepressants. We do note, however, in the manuscript that there may be an underreporting of depressive disorders. Patients may certainly have undiagnosed depression, as is common in the general population, and also that in some cases, medications used to treat depression can have other indications, for example, to help with sleep. And so there is a little bit of inherent uncertainty in that case. But using that information, using to the best of our understanding, we were able to ascertain how many were carried a diagnosis or received treatment for depressive disorder.
Thanks for that. So basically, this Beck inventory asks questions and you get a score. 11 was used in the cutoff of depression for this study, given its use in prior studies. 63 would be the highest score achieved. So maybe first we'll start with table 1 and just look at this cohort of 283 patients.
At baseline, 44 patients met the criteria for high depressive symptomatology. Overall, the characteristics of the patients are similar to what you would see in autosomal dominant polycystic kidney disease. And just to note, for nephrologists who are perhaps not specializing in the treatment of this disorder, these are patients that tend to be substantially younger than patients with other causes or more common causes of chronic kidney disease, such as hypertension and diabetes. We actually noted the patients who had high depressive scores compared to those with lower depressive symptom scores were not dramatically different in major demographics or in the severity of their kidney functional impairment. The primary distinction between these two groups of patients was actually in the level of education. So those who had low depressive symptomatology were much more likely to have higher levels of educational achievement than those who had high depressive symptoms. The PKD severity and the PKD risk classification based on the size of their kidneys for age were actually statistically indistinguishable between the two subgroups. Finally, in looking at other patient-reported outcomes and chronic diseases, what we noted was, as expected, that those who had high depressive symptoms were more likely to carry a diagnosis of depression and more likely to use antidepressants. This is expected because, of course, having high depressive symptoms should be and would be an indication for consideration of treatment and for the development or investigation of a diagnosis throughout their primary care and hopefully throughout their nephrology care as well. The other thing that we noticed was that those who had high depressive symptoms, half of them reported frequent, that is, at least daily pain either in the flank, abdomen, or back, and pain, of course, being one of the major patient-reported manifestations of polycystic kidney disease, and one that can be quite functionally disabling and interfering with quality of life.
Oh, very interesting. So just to summarize some of that and maybe see if I got it right, looks like about 15% of patients had that score greater than 11, which would indicate potential depression, I guess we'll say. A couple of things about table 1 that was really interesting to me was it seemed to be the score greater than 11 seemed to occur in individuals that had lower education.
Yes, that's correct.
And then pain associated with a higher score. Interestingly enough, and maybe I didn't get this right, the other one was interesting is that the family history of end-stage kidney disease actually had lower scores on this Beck depression inventory. Is that correct? And that would be opposite of what I would have predicted. What are some thoughts on that?
Yeah, no, that's a good point. So we were surprised by this finding as well. One thing I would say is, again, that this comparison is simply what we would consider a univariate comparison. So it doesn't take into account other differences between those who have a family history and those who don't. Ascertaining family history in ADPKD, of course, is an extremely important part of making the diagnosis and also making the prognosis of the disease. But it can be very challenged because it depends in part on the size of one's family, and also having information about your direct family members. And there are many patients for whom information about their affected family members is simply incomplete or absent. We also found, as Carolyn looked into this, accounting for more of these other demographic potential confounders or covariates, that difference was markedly attenuated after we accounted for some of those. So we think that this might be perhaps even either a chance finding or one that is confounded by other demographic differences between those with and without a family history of end-stage kidney failure.
I guess going into it, I was thinking that knowledge of end-stage kidney disease at an early age, but I guess we don't really ask that. The question's more of just, do you have it in the family? Would be very strongly predicted to cause depression or lead to progression. So that's very interesting. One, that it's there, but two, I guess it does go away with the adjustment, but still it doesn't appear to be positively associated with it. So that's very interesting.
Tables 2 and 3 describe the association between the progression of ADPKD as defined as the eGFR and the total kidney volume and depressive symptoms. And the most significant finding in that table is that frequent pain is the only thing that we found to be significant in affecting the association between ADPKD disease progression and depressive symptoms. Notably, gender, education, age, race, BMI, those were not found to have significantly influenced the progression of depressive symptoms.
And it was pain, the association of pain and depression, or I should say this is frequent pain and depression, because many PKD patients have reported at least some episodic pain. But in this case, frequent pain, the association was actually quite strong. So the standardized regression coefficient was over 0.5, indicating a moderately large association independent of other factors. We were somewhat surprised by the fact that the kidney volume was not associated with it, nor the GFR, again, thinking that as the disease progressed, that depression would get more severe. This does, though, track a little bit with what's been reported in some other large cohort studies, that kidney volume itself is not a very close correlate of the pain and health-related quality of life that patients are experiencing. Or if it is, it's a very much of a nonlinear relationship, and where it's only at the most severe subgroup with kidney enlargement that it's related. And patients can have very large kidneys and report really minimal pain. And some patients can have only moderately enlarged kidneys and report very severe pain.
That's very interesting. I'm trying to wrap my brain around that. So just as you showed in table 1, where the presence of family history of kidney disease might be a pretty strong correlate to kidney volume and other metrics. Those are all very tightly linked. And so when you look through the kidney volume, that really didn't seem to bear out and showing a correlate with depression, maybe very similar to the family history. The pain is very interesting, and how you sort of discuss that. And to me, like, that's something that I think is a really good take-home message about frequent pain. Doesn't necessarily mean they have a certain size of kidney, for instance. It just might be some sort of inherent, maybe where the cyst is, or something about their anatomy that is unique. So curious about this is, and I'm sort of thinking about this, were any of these patients on tolvaptan or other therapies to slow cyst progression, and does that alter the depression?
There was a very small number of patients in this cohort that were on treatment with tolvaptan. And remember, this cohort also started enrolling in 2013 before the availability of tolvaptan and its marketing approval. So the number was too small for us to assess what the relationship with tolvaptan and depression. Of course, we know that tolvaptan does slow the progressive enlargement of kidney volume. Whether that would translate into less depression ultimately, I think, is, to my knowledge, still an unanswered question. I would just note that in our study, that kidney volume enlargement doesn't seem to predict depressive symptoms, that one might think that the effects of slowing that progression would be relatively minimal on depression.
Well, also thinking about pain and kidney disease in general, it's a really tough topic. We don't have a lot of good therapies to give these individuals. NSAIDs have been not very well accepted in our community for a variety of reasons, some of which are very good. Opioids obviously have their issues. Does this also show that maybe we as a community have not addressed pain like we should have or can?
Yes, I think that is one of the conclusions that we drew, was that pain, in addition to it's naturally interfering with function, does seem to also lead to, as one might imagine with psychological distress and depressive symptoms. The treatment of pain is, of course, as you know, very complicated in PKD as in other kidney diseases. Most of our patients are instructed to avoid or at least severely minimize NSAIDs, although those medicines can be effective at pain in generally. And of course, the enormous national focus on minimizing the use of opioids also makes that option sometimes very challenging for patients. Anecdotally, it seems that many of our patients do suffer, when they do suffer from pain, they suffer it without necessarily frequent pharmacotherapies. And that might be something that we want to rethink as we consider the whole patient and not just their kidney function.
So we hit the treatment of pain, which I think that's a key one here. Anything else on these associations?
We were expecting or hypothesizing to find a increased prevalence of depression compared to people in the primary care population or perhaps people with other chronic diseases. Now, we were taking advantage of the fact that we're using such a widely utilized depressive instrument to compare it to what's been published using the same instrument in other patient populations. And in fact, what we found is that the prevalence of depression was not increased in our patients. And that was true both across the entire age range. And it was also true looking at elderly patients and comparing them with patients with other kinds of chronic kidney diseases, for example, depression and hypertension. So that was an unexpected finding in our study. And it contradicted slightly some of the focus of other studies, which have suggested that symptoms of depressive or psychological distress might actually be more common in PKD.
Carolyn, when you're talking now to others about your project, what are the major take-home messages that you'll tell them about what you found?
The major take-home message from this paper is that pain control is really important in this population, and also that this patient population has a number of incredibly resilient individuals who have found a way to make their lives meaningful and enjoyable despite having this chronic progressive disease. One take-home message for providers and physicians is that physicians who are treating patients with ADPKD find themselves in a pretty unique position because they follow these patients over a really long period of time. And in the psychiatry literature, it's often noted that the patient-physician relationship can be a methods or a means of treatment in addition to all the standard medical therapies. So for nephrologists who treat patients over a really long period of time, the relationship is actually quite essential.
Yeah, I like that. That's a great way to put it. And that's one of the reasons why we all go into the field, is to have these great relationships. One of the things is that, from what I've heard from patients, is that now that we're getting therapies for polycystic kidney disease, it's giving them some ownership, some hope. How do you think some of those things impact depression on the larger scale for ADPKD?
That's a really important point. We have, of course, now an FDA-approved therapy. There are lots of therapies that are undergoing testing, including in phase 3 clinical trials. We have focus now on diet and other lifestyle interventions that any patient can utilize and take up. And the sense of ownership and control, I think, is very important. This is a group of patients that are in many ways extremely well organized on the level of patient advocacy and peer mentorship through various nonprofits like the PKD Foundation and others. And this is, I think, a really essential component of them, what Carolyn referred to as their psychological resilience in facing a organ-threatening inherited disease.
Well, thank you so much for joining us on the ASN Kidney Translation Podcast. We really appreciate it. And we are also very much looking forward to Carolyn Yee's next project and hopefully her ascension into the field. Thank you so much to both of you.
Thank you.
Our last manuscript to cover is published in CJASN, titled Predicting Kidney Outcomes in ADPKD, a comprehensive biomarker analysis. We have the first author, Dr. Bays, joining us on the ASN Kidney Translation Podcast. Welcome.
I'm one of the PhD students currently working at the UMC Groningen in the Netherlands at the Department of Nephrology. I am a medical doctor and I've worked for about 3 years, and currently I'm in the last year of my PhD wrapping up, and I aspire to be a nephrologist.
Fantastic. We're really happy to have you join the field. And this is a very interesting article. A lot of attention is being put on to how do we predict progression in ADPKD, and a lot of biomarkers are out there. Also, the challenge in patient care, when you see a patient, you try to understand what their trajectory is. Some of those patients in the middle of the Mayo classification, say in the 1C range, can have widely different trajectories. And I think the goal is to improve our ability to prognosticate who will end up on dialysis, who will end up needing a kidney transplant. So I think this is a very timely paper. Can you tell us a little bit about the challenges that the field faces in biomarker analysis and why this paper was sort of put together?
The main challenges currently for us in this field is that we have done quite a lot of studies over the years using biomarkers in ADPKD, also in our DIPAC cohort, which is currently one of the largest ADP cohorts in the world. But in order to really make the next step towards using these biomarkers in clinical care, we have to find a way to directly compare these biomarkers to each other, because we've done so many articles that vary a little in what inclusion criteria are used. So which patients are we using for those studies? Which covariates are we correcting for? And that is one of the big challenges moving forward, is which of these biomarkers should we really pick to implement in clinical care? And in order to make a good comparison, we need to kind of line up these biomarkers and use the same statistical models to compare them. So that is the main reason for us to perform this study.
Well, before we move on, maybe you can describe what the DIPAC consortia or group of patients is.
Yeah, so the DIPAC consortium, the DIPAC cohort, is a prospective study in patients with ADPKD. And we try to follow these patients over the years without any inclusion criteria. So we try to include all ADPKD patients ranging from 18 years onwards with all sorts of kidney function impairment. And we try to really get a representative sample of ADPKD patients in order to perform research like this study where we study disease progression.
And where are the patients located? What countries?
Currently a national collaboration between 4 universities in the Netherlands, located in Groningen, Rotterdam, Leiden, and Nijmegen, so throughout the Netherlands. And currently we have about 700 patients included in this study. We have MRI, so kidney volume measurements every 3 years, and yearly we look at the kidney function.
Before we talk about all the different biomarkers, can you tell us a little about the current state of risk prediction is in clinical medicine for ADPKD?
Yeah, so currently we have mainly 2 tools. The most important one that is used currently is the Mayo Clinic classification, which is an index of kidney volume versus age. So in essence, you measure kidney volume once using a CT scan or MRI scan. Then you can calculate the average growth rate over the past few years in that patient. And that gives you an indication of how fast the kidneys are growing. And that is related to kidney function decline. So that is one of the risk tools, the Mayo Clinic classification. And the second major risk tool is the PRO-PKD score, which is a score that uses both mutation type and certain clinical variables that we use to assess the risk of future rapid disease progression, risk of progression towards kidney failure. So those are the 2 tools.
And how do both of those perform in patients? And obviously there are limitations. The risk score uses the genotype. You got to have someone's genetic information or they can't even use that score. If you have all the information, how well do they both perform?
Yeah, there are downsides to those risk tools. But at the same time, for example, the Mayo Clinic classification is a very simple tool that performs reasonably well when you look at groups of patients. So if you look at a cohort, large groups of patients, then the Mayo Clinic classification, for example, generally predicts kidney function decline. We previously published an article where we showed that if you look at the predictions from that classification and then look at individual patients, there actually is quite some variability in, for example, eGFR slope. So in the eGFR decline over time, there's quite some overlap between Mayo Clinic class 1A, 1B, 1C, etc. And so there is room for improvement there to really optimize the kidney function decline predictions in individual patients. And for the PRO-PKD score, generally that's the same. That those risk scores and tools work quite well in large groups, but for individual patients, there is room for improvement.
Well, there's a lot at stake in this risk prediction because that's how we're currently offering therapy, which not only do you want to find the right patients to take the therapy, but if they do take the therapy, you want to ensure that it's worth it, meaning that the side effect profile that you'll get from the therapy will make an impact in kidney size and volume and progression of kidney disease. So this is a really important topic. Let's move on to your paper, and you use this group of patients that you've been following in the Netherlands called the DIPAC Consortia of roughly 700 patients. How do you decide which biomarkers that you used?
Yeah, so that's a good question. The biomarkers that we used in this study have been measured over several years. Some of them are biomarkers that are known in other diseases to be predictive of kidney function decline. The major one there, for example, is albumin creatinine ratio, of course, that is related to a lot of kidney diseases and also to ADPKD. And then there are other biomarkers, some of which are more ADPKD specific, like copeptin as a measure of vasopressin production. We know that vasopressin plays a very important pathophysiological role in ADPKD. So using copeptin in that case is a very sensible biomarker to study. And then there are other biomarkers that are known from other diseases and that reflect different parts of the different pathophysiological processes in the kidney, like tubular damage markers and some other markers as well. So that's how we selected these biomarkers. Also, because there are so many biomarkers that we can measure, right? But for this article, we really tried to focus on the biomarkers that in previous articles were already shown to be associated with disease progression in patients.
So in essence, this paper wasn't trying to find novel biomarkers, but take what has already been done in the literature and utilize it on a larger population and also do them all at the same time. Whereas oftentimes in articles past, it might be one article in one paper and another biomarker in another paper.
Exactly, because it's so difficult to make a comparison between the biomarkers at the moment, because all the articles that we published previously have different statistical methods, use slightly different patient populations. Although they all studied patients from DIPAC, there are still some subtle differences between which patients do you use for this analysis. And that makes it really difficult to compare. So in order to really make the next step towards clinical implementation, to use these biomarkers in clinical care for risk prediction, we needed a study that compared these biomarkers using exactly the same patients and exactly the same statistical methods. So that is really why we performed this study.
Well, now you can tell us a little bit about what was the methodology that was used for this paper?
We looked at several clinically relevant endpoints in patients with ADPKD. Of course, one of the main points is eGFR slope, so the rate of eGFR decline. And then there are two other relevant endpoints in patients with ADPKD, that is rapid disease progression, which currently is defined in ADPKD as an eGFR slope of more than 3 milliliters per minute per year, so an eGFR loss of more than 3 per year. And that endpoint is relevant for us, especially in Europe, because our European guidelines recommend to use that cutoff value when considering to initiate treatment with, for example, tolvaptan. So that's the second endpoint. And then the third endpoint was a combined endpoint of a 30% eGFR decline or the development of kidney failure.
One of the questions I had was, since this was a pooled cohort of patients that are being followed prospectively, does it include patients that are on tolvaptan?
Our cohort does include patients who are on tolvaptan, but for the main analyses in this article, we excluded those patients because it affects eGFR decline.
It could also affect some of the biomarkers, for instance, copeptin.
Exactly, yeah. So we have part of our patients are already using tolvaptan at the baseline visit, so at the very start of the visit. And in those patients, tolvaptan might affect the biomarker levels, especially copeptin, like you said, but potentially also other biomarker levels. So that's why for the main analyses, we excluded those patients.
Can you tell us about the baseline characteristics of the patients that were included for this study?
So the baseline characteristics for the cohort that we used in this analysis, we had 596 patients, so almost 600 patients of which approximately 60% were female. The average age at baseline was 47 years, and the average eGFR at baseline was 63. When you look at the Mayo Clinic classification, most patients were in Mayo Clinic 1C, which is what you would expect for an ADPKD cohort of this size. And also when you looked at the distribution of CKD stages and also mutation type, those were also generally well-rounded and what we expect from a general ADPKD population.
And what about the pro-PKD score?
The pro-PKD score, there were about 12% of patients had a high-risk pro-PKD score, so that is a pro-PKD score of more than 7. And then there were about 36% of patients had a low risk, and another 36% had a medium risk pro-PKD score. But I have to say that the pro-PKD score is not available in a subset of patients who are less than 35 years old and who have not yet developed clinical complications like hematuria or flank pain, for example. So the pro-PKD score was missing in this subset of patients that are young, which is also why we mainly use mutation type in our analyses and not pro-PKD score.
So in this cohort, every single patient has mutational analysis?
Yes, we perform that in every patient. There are some patients in which no mutation was found.
We got the patient population that we're looking at. We have a lot of different things that we're going to measure. How did these new biomarkers perform?
We looked at 13 biomarkers in total, and looking across the endpoints that we investigated, so eGFR slope, rapid disease progression, and that combined kidney endpoints, we found that there were 3 biomarkers that generally were independently associated with these endpoints. So after correction for other covariates like age, sex, baseline kidney function, Mayo class, and also mutation type, so correcting for quite a lot of variables, there were 3 biomarkers that were independently associated with the endpoints, and those were albumin creatinine, MCP1, and also copeptin.
Wow. So good old albumin, urinary albumin wins the race. That's very interesting. Was that something that these 3 biomarkers, were you all expecting that, or was this a surprise?
I think the biggest surprise for us was albumin, because albumin, of course, is generally associated with CKD. Albuminuria occurs in many forms of CKD, but ADPKD is not classically viewed as a glomerular disease. So initially, we did not really expect to find that albumin creatinine was associated independently with all these endpoints. For the other biomarkers, so MCP1 and copeptin, MCP1 did previously perform quite well in one of the studies by my predecessor, Leon Messendorf, and it is associated with inflammation in the kidney. I guess copeptin was kind of what we already expected based off of previous studies and also based on the pathophysiology. So when you think about the fact that tolvaptan currently is still the only renoprotective drug that we have available for ADPKD, and copeptin, of course, is a measure of vasopressin production, we expected that copeptin would be associated with these endpoints.
And I think one thing that you said that I just want to verify is that these 3 were statistically significantly able to predict progression independent of genotype and also kidney function at baseline and also size of the kidney at baseline?
That's right. So we used models that included all those covariates because those are covariates that usually we have available in the clinic for our patients. So we really tried to mimic the scenario that we have in our outpatient clinic, where we have all these variables available, and then ask, okay, so which of these biomarkers can tell me more about this patient and will be informative of the prognosis of this patient. So we corrected in our models, in all of these models, for those covariates.
Also, I noted that 2 of them are urine biomarkers, the urinary albumin to creatinine ratio. We know that one very well. And then the MCP1 to creatinine ratio. And then the third one is a serum sample of copeptin. So that's very interesting at 2 urine and 1 serum. Just trying to think about the feasibility of doing this. 1 we already measure, so that's great. And so adding on the other 2 might not be a big challenge.
That's right. And also thinking about the feasibility, we try to focus as much as possible on spot urine samples because, of course, collecting a spot urine sample is much easier for patients than collecting 24-hour urine samples. So, and as you said, we already measure albumin creatinine in our patients, usually in spot urine. So adding MCP1 to the spot urine measurements, I think, is feasible. And also, of course, we collect blood samples quite often in our patients as well. So measuring copeptin in those patients will also, I think, be quite feasible.
When I'm looking at that figure 1, panel B has the early disease, and then panel C has that classification 1C, another challenging subgroup. And it looks to see how these biomarkers sort of function right next to the Mayo classification score, the ProPKD score, and then adds them on. And you can see that the addition of these biomarkers improves this test and prediction. So I think that's wonderful. One question is, I don't see anywhere where they just use the biomarkers alone. Do they perform to any degree similar to the other ways we predict kidney function decline?
Yeah, you're right. We focused on adding the biomarkers to clinical covariates because those clinical covariates are what we use currently in the clinic. And you wouldn't really use a regression model or a risk score where you use only biomarker levels. So we didn't, in this article, look at logistic regression models where we put only biomarkers. But that is definitely an interesting question. And also, you would be able to investigate the combination of biomarkers. So does the addition of both albumin, or the combination of albumin, MCP1, and copeptin, how does that perform compared to smaller regression models where you have only MCP1 and albumin, for example?
I'm curious about using kidney failure risk equation, something we use very common. I mean, obviously it has urinary albumin creatinine ratio, same biomarker used in this study. How well does that perform in predicting outcomes, and maybe even layering that on top of, is that something that has been done before? Is that something y'all considered adding to this?
That's a really interesting question. That is not something we looked at in this current article, but that's definitely a good thought, and definitely something I could add to the analyses later to see how well it performs.
Well, this is a really wonderful study. Can you tell us about what the next steps are? Are we ready to take this to the clinic, or do we have more work to do to refine this and to ensure that it is holding up in other studies and populations?
Yeah, that's a great question. I think that a lot of biomarker research, the question is, how do we apply this in clinical care? And I think one of the challenges, like we discussed earlier, is standardizing biomarker assays. So measuring MCP1 in Groningen, in the Netherlands, should be comparable to measurements in, I don't know, say Sao Paulo or somewhere else in the world. So standardizing those assays really is a big challenge.
Well, there's definitely a lot to think about here. And as I am sort of trying to process this, I'm thinking about copeptin. And one of the problems I see is that, is it possible to really change the level of copeptin based upon, how much water a person's drinking, for instance? And does those sort of things need to be looked at so that when you have a patient coming in that, maybe on a Monday was traveling for the weekend, might have a higher copeptin level than someone who might have been home all weekend drinking water or even preparing for their visit, could suppress their copeptin level. So is there any physiologic issues that we need to think about when measuring some of these biomarkers?
Yeah, definitely. I think that, of course, you can, like you point out, affect your vasopressin production and copeptin by drinking. So in a study like this, I mean, we of course have standardized ways of measuring copeptin. Patients come in and have a fasting blood sample drawn. And of course, if you were to implement these biomarkers in the clinic, you would need to standardize the measurement and blood draws in a similar way. So standardizing those assays really is important.
Thanks to all of our guests for joining us today, and a huge shout out to our listeners. Join us next time on the ASN Kidney Translation Podcast.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.